you for standing by. All participants are in a listen mode until question and answer session of today's conference call. If you would like to ask a question, you may press star followed by the number 1. This call is being recorded. If you have any objections, you may disconnect at this point. I'll turn the meeting over to Ms. Renee. Ms. Renee, you now begin.
Thank you. Welcome everyone to our Midwest Quarterly Stroke Webinar Series. We're pleased to have you on the call today. And we also have a guest speaker to discuss our relationship between AFib and stroke. So thank you all for joining. Everyone was able to log into both the call and web portion of today's webinar. We've provided contact information for Kristen Matthew. Please contact her should you have any trouble being able to hear the audio or to see the slides. Be sending a copy of these slides after the presentation, but Kristen can send them to you now if you are having trouble viewing slides on your screen. This is part of our, of course, quarterly webinar series, and these webinars are open to all parties interested in improving stroke care, and we've had a really diverse audience: nurses, stroke program coordinators, neurologists, medical directors, and other quality improvement personnel from our Midwest region. And this is really to engage in educational opportunities, to ask questions, to hear from experts in the field from your state or from states in the surrounding Midwest region. These are scheduled for 1 hour on a quarterly basis. And our next webinar, we're still finalizing the date, but we should have that in the next month. So we will send out that information to everyone who attended today. I'll have an optional networking group where you can connect directly with other hospitals, those who attended these webinars and others who have opted into this group. If you'd like to join, please go ahead and contact Kristen Matthew, and she is the person who also sends you the reminder, so you can reply to that email and let her know that you'd like to join the group. Currently at just under 300. What we're at here, this is a map of all of the kind of show the representation of our Get With The Guidelines data. We're going to show you a few reports. We'll go over those in a few slides. But the map shows the saturation of acute ischemic stroke population that come from hospitals that are using Get With The Guidelines stroke. The West region, about 75% of the acute ischemic stroke population are represented by hospitals using Get With The Guidelines. So when we look at regional, state, regional, or national reports, it is very representative of the full stroke population. And we'll be going over, my colleague Lynn will be going over a few reports in a moment, but just as a reminder, hospitals that use Get With The Guidelines have access to generate reports for your individual hospital, of course, but also at the state, regional, national, and other aggregate benchmark level. And this is an overview of instructions to generate the reports from your account. You can also always reach out to your local AA Quality and Systems Improvement Director, and we've included the contact information for everyone towards the end of this presentation. But this gives you just a few steps once you're logged in to click on Reports and then to click on the Configurable Measure Reports page. And that's where you can build your report according to the time period, the type of report, the display, and any comparison benchmark groups and options that you'd like to see. So you create custom reports to look at hospital, to look at benchmark groups, and Lynn is going to go over a few of these reports, really focus on the relationship between AFib and stroke. So Lynn, I'll hand it over to you from our webinar today. Thank you.
Thanks, Renee. So we're going to go into some of those benchmark reports. As you know, our speaker today is going to be talking about atrial fibrillation and underdiagnosed but dangerous epidemic, and we really wanted to emphasize the relationship between atrial fibrillation and the risk from stroke. So to just a little general overview, there are approximately 2.7 million individuals that currently suffer from atrial fibrillation. That number is expected to double by 2050. Atrial fibrillation patients are 5 times more likely to experience a stroke. With the presentation materials for today, we'll be sending a one-pager that has these statistics on it for you as well to reference. Please. To give you some examples of data that we were able to pull, and as mentioned, you're able to pull these reports for your individual hospital as well as these Midwest region benchmarks and national benchmarks as well if you are a guideline stroke participating hospital. So to give you examples of the reports that you can look at to really look at the relationship between atrial fibrillation and stroke, this is one example of the ischemic stroke subtypes. So look at data from 2016 to thus far in 2018. The patients that are coming to a Get With a Guideline stroke hospital that have a documented potential cause of ischemic stroke as cardioembolisms is between 14 and 16%. Actually is a range of 8,400 to 13,000 patients. So that's the amount of patients that are coming in with a documented potential etiology of cardioembolism as their cause for ischemic stroke. Next, please. An example to that is the patient's medical history. So with the guidelines, stroke participating hospitals, again, looking at 2016 to thus far in 2018, approximately 16 to 17% of our patients have a documented medical history of atrial fibrillation. Next is that for our Midwest Get With the Guidelines stroke hospitals, they do a really excellent job of treating our stroke patients that have atrial fibrillation. Since 2015, our to measure discharge on anticoagulation for patients with AFib has been over 90% compliance. Great there. I'd like to take a moment to congratulate our 234 hospitals across our Midwest affiliate that have achieved excellence in recognition for stroke or atrial fibrillation care through our With the Guidelines stroke or Get With the Guidelines atrial fibrillation. So congratulations to all of you. Thank you so much for your commitment to providing high quality care to your patients. Next, one of 234 hospitals recognized for their excellence is Aurora Bay Care Medical Center, located in Green Bay, Wisconsin. Aurora Care Medical Center is currently recognized as a Get With the Guidelines Stroke Gold Plus, Stroke Honor Roll Elite Plus, Get With the Guidelines Heart Failure Gold Plus, and With the Guidelines Atrial Fibrillation Gold Award Achieving Hospital. We are pleased to welcome our guest speaker, Dr. Mehta, from this award achieving hospital today. Dr. Mehta is the Medical Director of Cardiac Electrophysiology at Aurora Bay Care Medical Center in Wisconsin. He did his internal medicine residency and cardiology fellowship training at Einstein Medical Center in Philadelphia, Pennsylvania, and his electrophysiology training at Stony Brook University Medical Center in Long Island, New York. His special interest is management of atrial fibrillation, is associated with heart failure. But thank you so much for joining us to present today. The floor is yours.
Thanks, Lynn. And thanks, everybody, for being here. So, what I wanted to talk about is, obviously, we hear about AFib and its correlation with stroke. And we do know that, with AFib, the risk for stroke, especially cardioembolic stroke, increases exponentially. But I also wanted to take this opportunity to just talk about AFib in general, just give a broad kind of overview of atrial fibrillation, what its prevalence is, what the factors are, what its hemodynamic consequences are, and all those things. Just kind of a broad overview of this problem, so that all of us are a little bit better informed about AFib at the end of this talk. So AFib is the most common atrial arrhythmia. In fact, the most common arrhythmia. The lifetime risk for AFib is 26% for men. This is for European descent because they have been the best studied population. 26% for men, 23% for women. But, the estimates are being revised now. You may have heard about a longitudinal study, the Framingham Heart Study, and there was a recent estimate that the lifetime risk of AFib is close to 35 to 37%. That's more than 1 in 3 people who, are alive. And it does lead to a five-fold increased risk of stroke, as, Lynn pointed out in the previous slide. The other thing about strokes with AFib is that those strokes are likely to be more severe, lead to neurological deficit. Because, if you go back to the previous slide that, showed about the type of stroke, as we know, a majority of strokes, we don't really know the etiology. They are undefined etiology or unknown etiology. Some of them are small vessel strokes, even though they are strokes, but they don't involve a lot of territory of the brain. On the other hand, when you have a cardiovascular stroke, that's a huge kind of thrombus that travels from the heart, blocks one of the major arteries, and usually the area of the brain involved is, large. There is a threefold increased risk of heart failure, and this may be outdated too, because what we've seen in our practice, it's probably more than threefold, and a lot of these things are very difficult to compute because they are based on epidemiological data, and sometimes epidemiological data is not super accurate because diagnosis of atrial fibrillation doesn't get documented till later. There is an increased risk of dementia, increased risk of heart failure, increased risk of stroke. All those things, all those comorbidities kind of increase with AFib. 500,000 hospitalizations. They are hospitalized more often, multiple admissions, increased mortality, and increased healthcare costs. A slide which is looking at the number of patients that have atrial fibrillation. Now you see, the patients who have AFib, if you look at different estimates, they are very, very different. They can vary from 2.7 million to 6.2 million. Why is there such a huge spread? There's such a huge spread because a lot of patients with AFib are just not diagnosed. Because the diagnosis of AFib happens with an EKG. And our patients never get an EKG. A lot of people never get an EKG. You see a primary care doctor listens to you for, 20 seconds and, that's it. Now, they find that, okay, you have an irregular heartbeat, but that's it. Or you may have an irregular heartbeat just because of, PACs, some extra beats, or PVCs. So AFib gets missed all the time. And that's, I think, variability in the number of patients that have AFib. But if you look at this, study published, it's estimated that about 6 million patients had AFib at this time. And the number of AFib patients is going to increase, and this is 2016, we're already here, increase to about 8 million or 9 million. And there are other estimates which say, okay, it's closer to 5 million. But the CDC estimates and the Framingham Heart Study, another thing, it's probably closer to 9 million at this time. And look, this UK population study, if the population of patients increases, right, but this increase in burden in relation. So there is projected to be an X exponential increase in the number of patients with atrial fibrillation over the next 20 to 30 years. You know, the standard for diagnosing AFib is on an EKG. And what an EKG tells us that it is AFib? The first important thing is it's an irregular heart rhythm. So there's irregularity to it. And, we can feel it with the pulse. We can, into the heart and auscultate. So the only thing we are seeing at that point of time is it's irregular. Monitoring, either a Holter monitor, a long-term outpatient cardiac monitor, or, there are a lot of new technologies out there now. I don't know how many of you have heard about AliveCore. We use that. That's like a software app that can be used for doing cardiac monitoring. Literally buy that equipment for like $100 off of Amazon or any of the online vendors. Apple Watch recently came out with their own kind of cardiac monitoring technology. But the gold standard for this is an EKG. And somebody, recently asked me, they're like, what do you think about the Apple Watch coming out with, this technology? And I'm like, that scares me because now, you have thousands of people wearing these watches, and guess who's going to be reading those rhythm strips? And it's going to be the EP office, which will be bombarded with, millions of rhythm strips. But it's a good thing that awareness is going out there, and people are recognizing that, okay, rhythms are also a problem, and they can sometimes, appropriate diagnosis and everything else can be very, very useful. So if you look at this EKG, fibrillary waves are there. This is irregular. You don't see any clear, what we call as P wave activity or AL waves. And this is like a classic prototypical example of EKG for atrial fibrillation. So when we talk about AFib, AFib is not created equal. I have patients all the time, and they're like, oh, I have a friend. The patient will come in. They'll be like, I have a friend. He had an ablation or cardioversion, and he's fantastic for 5 years, and nothing has happened to him. On the other hand, there may be another patient who comes in and, a friend who had an ablation procedure, and he went back into AFib, right away. And one person would think, AFib ablation is awesome, and the other person may think AFib ablation sucks, or therapies to keep you in normal rhythm. But I think we or that not recognize that much is that person has AFib. That doesn't mean all AFib is kind of created equal. In AFib episode, if a patient has AFib that lasts for, let's say, 5 minutes and happens once a week, a very different type of AFib than AFib in which a person has been in AFib now for several years a stretch, and heart has been completely remodeled by that AFib. So both these patients technically will be classified as AFib patients, but they come from very different places. They have very different circuitry of the heart, very different remodeling of the heart. So the one truism about AFib is that AFib type of begets AFib. The more AFib a person has, the more difficult it becomes for us to treat that AFib or to keep that person in normal rhythm. So the technical kind of classification of AFib is paroxysmal AFib, which terminates spontaneously within 7 days of onset. Persistent AFib is AFib that has been there for more than a week. Now, of the patients that we see are persistent atrial fibrillation. And long-standing persistent atrial fibrillation is AFib that has lasted for more than 12 months. And unfortunately, a lot of patients that we see also fall into this category. And once it gets more than a year, it becomes very challenging manage and challenging to, you know, convert and keep in sinus rhythm. Permanent atrial fibrillation really means that AFib has progressed to a point that both the treating clinician and the patient have made a mutual decision that both let the patient be in AFib rather than make attempts to convert to normal rhythm. So in atrial fibrillation, a lot of different things happen to hemodynamics, to how the blood flows, to what the blood pressure does, to what the heart, what is happening to the heart. So first of all, the suboptimal ventricular rate control. The ventricle is being fast, contracting fast. And there have been some very interesting animal models of what is tachycardia-induced cardiomyopathy. In other words, the rate is fast, and that leads to decreased ejection fraction, heart failure, and all those things. Now, since the atria are not contracting regularly, in fact, they are kind of fibrillating, so there's loss of coordinated atrial contraction. There can be beat-to-beat variability in the ventricular filling because irregular. And if you kind of think of it, irregular filling also leads to irregular ending of the heart. And all of a sudden, the entire body is getting blood flow that is variable with that beat. Your knees, your brain, your gut, every single part of your body is getting variable blood flow with every beat. That confuses the organs, confuses the kidneys. That leads to more secretion of, angiotensin, all those hormones, and they're not good. And that leads to sympathetic activation. And there can be some decreased cardiac output too with this. There's a study done, you see over here. This is, one of my favorite studies. This was done in the 1960s. 1968 was the public for this. And what they did is they put, that time when they first started cardioverting patients, and that was like new and amazing technology that they could shock the patients and get them in normal rhythm. So they put catheters in these patients' hearts and cut them, and immediately, from atrial fibrillation to normal rhythm, and immediately after the cardioversion, the parameters within half an hour, the hemodynamic parameters improved. This is the pressure, the PA pressure, the RV and diastolic pressure, the right atrial. Like, this is in half an hour. You can imagine, if AFib keeps on going on, how bad the hemodynamics become. But can get them in normal rhythm. The hemodynamics do improve tremendously sometimes. What I was talking about, some of the animal models of what we call as tachycardia-induced cardiomyopathy. So what they've done is they've paced animal hearts at fast heart rates. So they've paced animals at like 200 beats per minute, 220 beats per minute for a few weeks. And, researchers have studied the animals prior to pacing and afterwards. And this is after 3 weeks of pacing. And this is the LV, left ventricular, average blood flow in red bars. And you see, a normal animal, LV blood flow is much higher. This animal has been paced for 3 weeks. The average blood flow has dropped more than 50%. It doesn't matter how you study them. You can study them at baseline. You can pace their hearts faster. You can give them chemical like adenosine, which dilate the blood vessels of the heart. Whatever you do, those that are being paced have effects of tachycardia on their heart. The average blood flow is significantly lower. And, then they, have looked at the mitochondria in those animals and look at mitochondria are the energy powerhouses of the cell, as you know, and look at baseline. Their mitochondrial density is very nice. Week 1 pacing, it drops. Week 2 of pacing drops further. Week 3, it drops close to 70%. And, the cells change. They've looked at it in several different ways. They've looked at the cells. They've looked at, mitochondria. They've looked at calcium channels, potassium channels. And every single place they've looked at, the damage has been tremendous in animals that have been paced for 3 weeks to kind of demonstrate this type of damage. So how do we treat AFib? There are two main strategies by which we treat AFib. Rate control. And rate control typically means, that we give medications to slow down the ventricular rate. We use beta blockers or calcium channel blockers, digoxin, even though digoxin is kind of falling out of favor for this. But we can use different medications to control the ventricular rate, or we can use rhythm control strategies in which we can either use medications to keep the heart in normal rhythm or use a catheter ablation or strategies. This, to treat rate control or rhythm control. But whether we choose rate control or rhythm control, anticoagulation is ended if somebody has a CHADS-VASc score of greater than or equal to 2. And I'm sure you guys are familiar with the CHADS-VASc, but just reviewing it. C in CHADS-VASc means congestive heart failure or a history of congestive heart failure. H is hypertension. If age is greater than or equal to 75 years, it gets 2 points. Diabetes, prior stroke or TIA or thromboembolism, again 2 points. Vascular disease, and that can include peripheral artery disease, MI, aortic plaque. Any of these will count as 1 point. Age 65 to 74 years gets 1 point. So if it's greater than 75 years, greater than or equal to 75 years, that's 2 points. 65 to 74 is 1 point. And if you're a woman, female is 1 point. Choice of anticoagulants. Coumadin has been around forever, and the target INR for that is 2 to 3. We have all these, we can call them NOACs or DOACs, whatever you want to call them. These new thinners, Apixaban or Eliquis, which is a factor 10A antagonist. It can be used twice a day. Rivaroxaban, most of them are factor 10As. Epidemic or Eliquis, Rivaroxaban, Xarelto, and Rivaroxaban, Surveillance. These are factor 10As, and dabigatran or Pradaxa is factor 2. Again, there's evidence that one may be better than the other in certain regards, but overall, all of these are pretty comparable to each other, and indicated for CHADS-VASc score greater than or equal to 2. These are all the antiarrhythmic drugs. I don't want to go into detail, but several drugs can be used to keep a person in normal rhythm. So then, we come to this big question: what to do about, how do we treat atrial fibrillation in a person? Like, what is the best strategy to treat it? Should we try to convert everybody to normal rhythm? Should we, do a rate control strategy and just try to control the ventricular rate? And, they've done trials on this now for the last, 20 years or so. This was a big trial published in New England Journal of Medicine in 2002. And what they did is, this is a big slide, but basically, if you just look over here, this was a very well done trial, and they compared 4,000 patients overall. They had 4,000 patients, so it was a big trial. And they put 2,000 patients in the rate control group, in which all they did is try to control the ventricular rate. It didn't try to convert the patient to normal rhythm. All they did was control the ventricular rate. And then they used a rhythm control group in which they did try to convert the patient to normal rhythm. And they had about 2,000 patients in each arm. What they found is the mortality and the adverse effects and everything else were pretty similar in both the rate control and the rhythm control group. So there was really no difference. In this trial, let me go back to your slide. The trial really, seeped into almost the subconscious of the, physician and medical community that, okay, it doesn't really matter what we do, whether we rate control or rhythm control. Now, mark it. The patients still need anticoagulation, whether they're in rate control or rhythm control group. But, the message from this trial was that whether we, try to convert to normal rhythm or we let them stay in AFib, they'll do equally well or equally bad. It doesn't matter. Now, here is, we would like to kind of point out a majority of these patients, like a vast majority of patients in the rhythm control group, were treated with medications, either amiodarone or sotalol. In fact, close to 63% of these patients were treated with amiodarone. And amiodarone, as we know, is a toxic medication. And the problem was that despite treating with amiodarone, a lot of them reverted back to atrial fibrillation because we know that antiarrhythmic drugs do not have tremendous efficacy and they do have significant adverse effects. But, and in this trial of about 4,000 patients, catheter ablation at that point of time was in infancy, and less than 1%. In fact, like 13 patients got ablation procedure, 4,000 patients. So, ablation was not even in the picture. It was antiarrhythmic drugs. And for me, the take-home message from this is that if you're only using antiarrhythmic drugs in this population of patients, you're not going to lead to an improvement in mortality or improvement in outcomes. But this was perceived as the medical community for that, okay, rhythm control or rate control are equivalent regardless of the treatment strategy. Because, it is difficult to, once it gets out there, it's very, very difficult to parse it or tease it, tease the relevant details from that message. But there were other trials performed at the same time or close to the same time. And this was published again in New England Journal of Medicine in December 2004. And in this, they looked at catheter ablation for AFib in congestive heart failure. And over here, when they did ablation, it was an observational study of 50 or 60 patients. And look at the ejection fraction. The ejection fraction after ablation improved for a vast majority of patients. And, there are all the parameters in which they are looking at the heart, and every single parameter showed tremendous improvement. Again, they showed an improvement in ejection fraction, improvement in all different parameters. Their conclusion was, and study was in 2004, so about 14 years ago. It's not unusual for us to hear, even in today's age, for people to say, oh, rate and rhythm control has equivalent outcomes based on a firm, even though there were other studies that were published at the same time or close to the same time that showed really different results, especially with catheter ablation. So, they showed that restoration and maintenance of sinus rhythm by catheter ablation without the use of drugs in patients with congestive heart failure and AFib significantly improved cardiac function, symptoms, exercise capacity, and quality of life. And since that time, there have been multiple studies showing the same thing. This was a study published circulation, and it showed significant improvement in ejection fraction. Then did another randomized controlled trial, pulmonary vein isolation, which basically means catheter ablation for atrial fibrillation in patients with heart failure. And they compared it to what we call as biventricular pacing, which means disconnecting the electrical connection between the atria and the ventricles by cauterizing the AV node and putting in a bi-V pacemaker, or doing atrial fibrillation ablation, and the outcomes are much better with ablation. So this is exactly what they are doing. And they did data analysis recently looking at all trials in which ablation was performed for congestive heart failure. And as you can see, ejection fraction before ablation was lower, and ejection fraction after ablation was improved. And this is based on meta-analysis. This is based on several different trials, and they've combined the evidence from those several different trials to look at the evidence. So, does this mean that catheter ablation is a solve for AFib, and if you have heart failure or something else, you can just have a catheter ablation and everything will be done? But I know both AFib and heart failure are dangerous kind of problems, are bad problems, and any improvement in those symptoms can have or a benefit in that disease process can have significant downstream effects, which can be very, very beneficial. And there was another article published in the New England Journal of Medicine, which called the CASTLE-AF trial, in which again, they showed significant mortality benefit and readmissions, and however you looked at it, there were significant benefits with catheter ablation for atrial fibrillation. How is AFib ablation really performed? Like, how do we do it? What happens during the procedure? This is the left atrium. And AFib, really a majority of the triggers or the circuits from AFib come from left atrium. And specifically from around the pulmonary veins. So the pulmonary veins drain oxygenated or carry the oxygenated blood from the lungs to the left atrium in pulmonary veins. And we have four pulmonary veins, left-sided pulmonary veins and the right-sided pulmonary veins. They drain into the left atrium. And what we really do is, the circuits for atrial fibrillation are located all around these pulmonary veins, both the left and the right-sided pulmonary veins. So this is an ultrasound catheter called an intracardiac ultrasound catheter. So we utilize this ultrasound catheter to go to the femoral vein of the groin into the heart, and then image the heart over there and study the heart. View of the heart, intracardiac ultrasound catheter. So we put a catheter in the heart, femoral vein, we can see into the right atrium, and on the right atrium we look to the left atrium. This is the left atrium, and these are the veins that you see over here. These are specifically the left-sided veins. This is the left superior vein, and this is the left inferior vein. And then, we cross over, we put another needle, a sheath and a needle into the right atrium and cross over to the left atrium. And when we cross over, do you see that? There's a needle that is pointed over here. This is the septum, intraatrial septum, the fossa valis, between the right atrium and the left atrium. And we put the needle over there under guidance of the ultrasound. The ultrasound probe is seeing this. And under ultrasound guidance, we put the needle over here, see this stenting, and puncture through the heart, and puncture to the intraatrial septum into the left atrium. And with atrium, we put different catheters in the left atrium. These catheters that are put in the atrium. In fact, over here, there are catheters in the left superior pulmonary vein, left inferior pulmonary vein, and right superior pulmonary vein. They're all circular catheters in different veins or the pulmonary veins of the heart. And use 3 mapping systems, which pretty interesting, which can tell us exactly. We can map out the heart in real time, and these systems are really like 3D mapping systems of the heart, like GPS mapping systems of the heart, and they can really tell us where the catheters are and what the heart structure is in real time. And subsequently, we deliver lesions or cauterization lesions all around the pulmonary veins. This a majority of the people are doing at this point of time, and this is by this, we can really one of the most effective strategies for dealing with atrial fibrillation. So the take-home points of this will be that AF can have significant effects on cardiac structure, function, and hemodynamics, and both afibrillation and arrhythmia-mediated cardiomyopathy is probably under-recognized. In failure patients, both rhythm control strategies with antiarrhythmic drug therapy have shown equivalent outcomes, but fibrillation has shown significant promise as treatment for atrial fibrillation. And I would turn over the speaker to Lynn.
Thank you, Dr. Mehta, for a really engaging and educational presentation. It was very well done. Thank you so much. I'm going to quickly turn it over to Renee for just a couple of quick announcements, and then following her announcements, we'll open the line for questions. So everyone just sit tight for a minute or so. Renee will do some announcements, and then we'll open up for questions. Back to you.
Thank you, Lynn, and again, thank you, Dr. Mehta, for a wonderful presentation, very engaging, and we're able to share this information with our Midwest audience. So the slide that everyone is looking at now are a few upcoming stroke events. So again, we will send out these slides after today's webinar. Please reach out to your local AH representative if you have any questions on these events. We do many AFib resources, both for professionals and patients. We've included a few links here, and we're happy to answer questions or find something if you don't see what you're looking for here. Links to several of our stroke resources, and these are also many for the patient education and experience, and also professional resources. Available free of charge, and they are all on public websites, so everyone can access these without needing any type of login. And this call was focused on stroke and AFib, and we wanted to remind everybody about our AHA's quality suite of programs. We do have an atrial fibrillation quality improvement model, and we'd be more than happy to share some information for our hospital about that module, as well as any of our additional modules in our quality suite. And there's a list of all of the local directors, so if you're not sure who to get in contact with, please refer to this list, or Lynn and I are also more than happy to help you. Okay, to open the floor for questions, and Carl, our operator, will give us instructions on how to unmute your lines for questions.
Thank you so much. We will now begin the question and answer session. If you'd like to ask a question, you may press star followed by the number 1. Please mute your phone and record your name clearly when prompted. Your name is required to introduce your question. To cancel the request, you may press star 2. One moment, please, for the first question. Once again, participants, to ask a question, You press star followed by the number 1. Give it 10 more seconds to see if there will be any questions.
Waiting for questions to be submitted. Lynn, I just have a quick question. If you can provide just a little bit of maybe information about the atrial fibrillation program that you have for your patients, maybe like any type of resources that you offer them or healthy behavior engagement, classes, patient, anything.
Sure. We have developed a program for managing atrial fibrillation patients, and as part of that program, what we've done is have developed protocols for the emergency department. So when patients come to the ER, there's a protocol in place that I developed in which patients can be managed appropriately both in the ER and discharged if possible, or get admitted to the hospital and quickly treated in the hospital. And that has had tremendous success. In fact, in the last year or so, our outcomes have improved, our inpatient admissions have decreased, our inpatient length of stay has decreased, our readmissions have decreased. So all those things have happened just with implementation of that protocol. I shouldn't say just with implementation. It's quite a lot of effort in implementing any protocol, but I think with implementing that protocol has happened. We are also fairly aggressive in seeing these patients in the office. Both either myself or my EP partner, we see them, or we have an APC team which can also assess these patients and see them in the office within 2 days of diagnosis and offer appropriate treatment. We have collaboration with our sleep specialists, because obstructive sleep apnea is a risk factor for that, with neurologists, with the dietary/nutrition people, and bariatric surgery. And because AFib is a multifactorial problem, and we believe that the treatment is best when a multidisciplinary team is really working on these different aspects or the different comorbidities. We are also focused on outcomes for both procedures and otherwise. We keep on monitoring what our outcomes are, what our completion rates are, what our maintenance of sinus rhythm is, and in all those aspects we are doing very well.
You have a wonderful, comprehensive program. Thanks so much, Dr. Mehta, for that overview. Do we have any other questions submitted?
There are no questions. There are no questions. No questions are on queue right now.
We have one more question for me. I heard rumors, Dr. Mehta, about an AFib yoga class. Is that something that you can just give a little bit more information about?
Sure. We have started a yoga program for rhythm issues and cardiac issues, and there is some evidence that both physical therapy and yoga can benefit these patients. And we have a fantastic yoga instructor in our sports and rehab center, and in collaboration with her, I started a yoga program for our patients, and the patients who have participated in it have reported significant benefit.
Thank you so much.
Mm-hmm.
Is there anything else that you would like to add before we close the call?
No, I am good. If you guys...
And this, I just want to thank you again, Dr. Mehta, for having how important it is to collaborate with your colleagues in other areas, especially since we have a lot of stroke professionals on the line. That's an excellent point and something that I think everyone can walk away with. Are there any other questions before we wrap up today? Okay, everyone, for joining us today. We will be sending these slides. Dr. Mehta, thank you for this information, this engaging presentation. We appreciate your time.
You're welcome, and thanks for having me.
Thank you so much, Dr. Mehta. Very well done. Thank you.
Thank you. Bye now.
That concludes today's conference. Thank you for participating. You may now disconnect.